Thank you. Well, dear colleagues, we'll discuss the use of AR in terms of angle closure, but I'd like to pay your attention to the issue of personalized treatment. That's the goal of AI, not just to detect the disease, but also how to tell them from one another. So let me just tell you that primary angle closure glaucoma is the main risk of blindness. The risk of blindness with PACG is 2.5 times higher than with POAG. You can see that we have paid a lot of attention to this problem when we had the person-to-person symposia. You can see during the pandemic, we started to organize online symposia, and the leading experts in the field of PACG were speaking here, Mr. Garzet, Mr. Alzara Blanca, Paul Forster, and others. Paul Forster, by the way, introduced this classification, which is being used globally. That's the kind of continuum of primary angle closure glaucoma, starting with the primary angle closure suspect toward the primary angle closure. When the optical nerve is affected, we discussed the primary angle closure glaucoma. Treatment at the early stage allows us to break this continuum and to prevent the development of angle closure glaucoma. This is possible only when we use imaging methods we have discussed during this discussion. Gonioscopy is one of them. Not everyone uses gonioscopy, but it will not be gone forever. But there are other methods present here, such as ultrasound methods, which are less available imaging methods, but also the OCT of the anterior segment is our future. We can measure lots of new parameters in the automated mode. We can apply it to the lens vault. We can also measure the lens volume, anterior chamber depth, and anterior chamber width. Also, we can measure TISA 500 and TISA 750, trabecular iris space area. So these concepts are very important, and as it has already been shown by our researchers from China, these are the indicators which would allow us to differentiate the conditions of the patients when gonioscopically closed angle will turn into PACG. Our data have confirmed these observations. Just see here, when we determined the thresholds for ASOCT, the angle width and the area, such as TISA will allow us to differentiate at the initial stage the angle closure and its deviation from the norm. For a long time, it was considered that in such cases, well, laser peripheral iridotomy should be performed, but studies conducted by those presenters who spoke here, the dark study showed that there is no need to apply LPI to everyone. Why? Because patients were monitored for 14 years. LPI was applicable to one eye, the second eye was the control one, and there was a reduction by 2/3 of the risk of closed angle transfer to PACG, but in general, this is a rare occurrence, so economically, it's not quite feasible to perform LPI for all patients. Now, the question is, who are the candidates for LPI and what can be done if the patient really needs LPI? We know that there are different mechanisms of angle closure related to the lens, to the iris, and other factors, or maybe there are things like choroidal excursion, well, not all mechanisms are in one eye, so it's difficult to identify just one parameter and to achieve success. That is why sometimes we encounter failure, and 1/3 of patients after LPI, we can see the progression of disease and not sufficient compensation of intraocular pressure. Like in this example, the reason is quite clear. When we do ASOCT, we can see the significant trabecular iris contact. You can see the coefficient is 32%. If the contact is significant, the pressure is not significantly low, the disease progresses. So here the question is to use another algorithm, another tactic. And here we recall another study, Eagle, which was done in 2016, and it showed us that already at the initial stage of angle closure, it is feasible to do the lens extraction, and together with LPI, this will lead to the significant reduction of ophthalmic tonus, the significant reduction in hypertensive drugs, and by a factor of 12, we will reduce the repeat anti-glaucoma surgery. Of course, these methods are very effective. The study continued for 3 years. Patients with the primary angle closure, when the pressure is more than 17.9 millimeters mercury, are candidates for LPI. Here are the indications for LPI, such as cataract, etc. Here, the situation is much simpler. But what should be done if the ophthalmic tone is less than 30? There is no optic neuropathy. We can see that the angle is closed. What should be done in this case? In fact, although it is known that the lens extraction and LPI have advantages, but we do not have quantitative indications when this algorithm should be used. Moreover, we remember about different mechanisms of angle closure, and the use of machine learning could help out here. So we've been doing this study over the last several years. You can see several works have been published on this topic in Russian journals and foreign journals. The goal was to develop a personalized treatment algorithm of primary angle closure by way of comparison of the results of lens extraction and laser peripheral iridotomy on the basis of our learning methods. We did not monitor a lot of patients, 6 patients only. We divided them into groups, patients with LPI, patients with lens extraction, but we determined different parameters, and that was enough to use the machine learning methods. 37 parameters, and for each patient, for each eye, we determined the choroidal thickness in 12 points of the parameters of the anterior segment of the eye, and these parameters were used to determine the criteria of success of treatment. Here we used the methods of main components or principal component regression, also to use 37 indicators right away, which correlate with one another. And for the first time, we used the one-class classification method offered by Professor Pomerantsev, our co-author, and for the first time, it was tested on patients with primary angle closure. How did it work? Look at this scheme. This diagram shows that each dot means a particular patient with 37 parameters. In the top of the slide, you can see patients before treatment, before iridotomy or lens extraction. Now, the brown line is the group with the suspicion of primary angle closure. We did not treat these patients. And then patients after treatment, at the bottom below the green line, that's the first-class classification, comparing the space around the target class. It was the norm, and you can see at this diagram that patients after lens extraction were in the area of the norm. Every third patient achieved normal indicators as far as these data are concerned. Unlike iridotomy patients on iridotomy, that's the blue line, you can see the dots here, they remained far from the norm, and the chance to achieve the target class was only 1/100th of a percentage. So you can see the comparison of the effect of lens extraction and laser peripheral iridotomy. Moreover, these methods allowed us to make a comparison of predictors of success of the treatment. Xu's presentation mentioned these predictors of laser peripheral iridotomy when we can count on a success, but before we did not assess all the parameters of the anterior and the posterior segment. In this work, we managed to do it. We identified the specific predictors of the success of lens extraction, such as narrow profile of the anterior chamber, angle in the lower sector, short axis length, high spherical equivalent, and the male gender. In male, the lens extraction works better in case of angle closure. Also, machine learning allowed us to make a prediction of the hypertensive effect of lensectomy. Well, to what extent, patients could be subjected to lens extraction and how the pressure drops in this case. That's the upper graph, and this allowed us to develop the algorithm of personalized treatment. Without going into details, I'd like to say that our goal was to use this algorithm as simple as possible, to make it as simple as possible, so the doctors would not just determine 37 parameters for each eye, but to determine just some parameters which are very accessible in practice. For example, age, short axis length, and the depth of the anterior chamber. And using machine learning, we proved that this shortened model of the choice can be developed and used in practice. We calculated the coefficients for each parameter. You can see them in this table, and you can see just the formulas. We just insert the data, and if the result is less than 0, then LPI is recommended. If ISF is more than 0, then lens extraction is recommended. What to do if the pressure doesn't go down? The question is, should we use local anti-hypertensive therapy in primary angle closure disease? The answer is yes, but they are not of high priority. If the pressure remains high after peripheral iridotomy, the patient doesn't agree to less lens extraction, we can use local anti-hypertensive therapy. There were studies showing the high efficacy of prostaglandin analogs as compared to LPI as far as these patients are concerned. This is an encouraging study showing that lantanoprost led to a decrease of ILP, which was 30.3 millimeters mercury. I think that any surgeon who deals with such patients can say that we can reduce pressure only to some extent when we use a medical treatment, then surgery is a must. Another group of drugs which turned out to be effective in case of angle closure, that's brimonidine. Brimonidine can even widen the anterior angle, normalize the chamber, and here is the drug which is new in our country, that is Brimiza. The range of drugs to low pressure is very wide. And of course, here we can talk about fixed combinations and new fixed combinations which can be used here, and not just the ones shown here, but you can see new drugs such as darzoprost. The study of this drug was done at the Helmholtz Institute, also such as latanoprost with other drugs, such as carbohydrate inhibitors. They are shown here at the bottom, such as trimargan or Dirtzob Plus. But colleagues, I'd like to remind you, as far as carbohydrate inhibitors are concerned, when we have the closed angle of the interior chamber, these drugs can lead to ciliary body swelling and choroidal effusion, and that is why we should use them with care as far as the choice of these drugs is concerned for such patients. Finally, what can we expect in the future because of the appearance of AI? I'd like to sum up what we have discussed during this discussion. Of course, well, the scleral spur detection, and this was mentioned by our speaker from the US, is of paramount importance because in practice we know how difficult to detect the scleral spur, and then all the measurements will be wrong, and AI can help us with the high level of reproducibility. This opens the way to diagnosis of closed angle, which has already been mentioned today. Also, you can see that there are opportunities to differentiate the angle from the open appositional or synechial ACA classification when we do gonioscopy, and in darkness and with light, we can differentiate whether it's organic block or not. That's very important for the prognosis. So, and I should say that this question was raised as far as photographic images are concerned. We just photographed the anterior segment of the eye and the quality of diagnosis when we have the narrow chamber or the narrow anterior chamber. They were the same regardless of whether this was done by the expert or whether it was done by AI. Finally, our Chinese colleague also mentioned the traditional colored gonioscopy. Here we can use this for open and narrow angles and to assess extent and severity of peripheral anterior synechia, and this means we can make the right diagnosis and choose personalized treatment. And of course, the future, as it has been mentioned today, lies in the use of synthetic imaging. When we can use a variety of different data, we do not need to think about confidentiality. This improves the quality of diagnosis and allows us to detect angle closure. So, colleagues, machine learning may become a wide-range method as a tool for diagnosis in case of closure, angle closure, but also opens up new possibilities for personalized treatment and to make a prognosis regarding the outcome. More important thing is AI can help us determine the pathogenesis of the pathology much better. Thank you very much. I would like to thank the co-authors who made a significant contribution into this study and all the doctors who also helped us get more material. Thank you very much.